Hello, I'm Tracy Williams. In this program, we're focusing on Indigenous eye health. Good eyesight is essential for cooking, driving, fishing, playing sport and many other daily activities. Our kids learn by watching, and they start life with better eyesight than non-Indigenous kids. But by the time they reach adulthood, they're 6 times more likely to be blind and 3 times more likely to have low vision.
Open your eyes wide as you can.
Up to 94% of this vision loss is preventable or treatable. Yet access to eye care services can be limited, and people often don't get the help they need early enough. Poor living conditions such as overcrowded houses and lack of clean water can also affect eye health. In this program, we'll look at how communities in remote Australia are working to prevent eye disease and develop services that make it easier for Aboriginal people to get the eye care they need when they need it.
So can everybody show me where their miller? You should have.
We'll visit Bulla, where the kids are learning about trachoma.
So we're going to show you some pictures, and Jack's going to talk to you about what happens if you get too much of this trachoma bug. So if you can share.
Then we'll travel to Katherine to see how the regional eye health program works.
So I'm going to demonstrate how that can affect your vision with these funny looking goggles.
Finally, we'll follow Dr. Tim Henderson to a remote eye clinic in Trichiasis and in Alice Springs conducting a cataract operation. Firstly, we'll go to the Bulla community west of Katherine to look at what they're doing to help prevent trachoma. Trachoma has been eradicated in many less developed countries, but is still endemic in some Indigenous communities. Catherine West Health Board and the community of Bulla are using the Trachoma Story Kit to educate children and parents about the importance of facial cleanliness.
Clean face, strong eyes.
The message is clean faces, strong eyes.
Catherine West Health Board covers a region that's approximately 2% of Australia, so it's a very large area. There are 7 communities in the region, so sometimes you will travel by 4-wheel drive to these communities. Some of them are 600 k's away from town. Sometimes you'll need to fly, and depending on the weather, they may be inaccessible. So to get there sometimes is one of the biggest challenges. The objectives of the Healthy Skin and Eyes program, and I think in particular the trachoma kind of initiative, is to improve the health and wellbeing of all community members. Australia is the only developed nation to have endemic levels of trachoma in its Indigenous populations, and trachoma is entirely preventable. It's a preventable form of blindness. The Trachoma Story Kits were developed with the Indigenous Eye Health Unit and the Numbin Reference Group, which are unique to Katherine in that they're elders and community members who help to guide the way in which we make health promotion resources.
My name is Jack Little. I'm living in the Bulla community since 1975, and I was the first Aboriginal health worker in Catherine West region. Well, my role is to educate my people while they're still young and make them be aware of all the health matter.
So we're going to show you some pictures, and Jack's going to talk to you about what happens if you get too much of this trachoma bug. So if you can share, and then we're going to collect them up. So there should be
See
enough.
this top one here? The image that called, that's the eyelid. When he turn in, he make it eye go manang, blind. You can't see. It's getting worse. Manang, okay?
Once someone has repeated episodes of trachoma, there's a chance that they'll develop trichiasis, which is an interning of lashes that rub against their eye, and if untreated that can cause blindness. So one of the aims is to identify those people with trichiasis and offer them surgery within an appropriate time frame. As a clinician, I think the Trachoma kits are valuable because they help you to, I guess, improve your skills in recognising trachoma and also trichiasis.
Well, with the kids, the Trachoma kit is really good because it actually shows you how they get trachoma and what happens and how you can prevent it and all that stuff. It's all about the education, the screening, and then the follow-up and the importance of hygiene. Because if you don't follow up with the hygiene, you may as well be flogging a dead horse.
You start getting runny nose because they didn't wash their face. And that's why this one got it now. You know, because we cannot see the germ that we're looking for with the natural eye. Only we can look at a microscope, all these little bad things in our mirror, all right? If they don't understand, well, I speak a language. I say, Yelamawanga, Wurlinjang. That means if you can't wash your eye got to go no good. Bug it up. Now we are lucky. We got a big river beside us, and we got to heat the water in the bathroom or wherever.
Your nose and your eyes.
So the kid can go and wash their eye, and they wouldn't get it. Out in the desert, too much dust, and there's no water at all. That's the reason too much. Out in the desert, they're getting too much bad. They come.
The trachoma team actually organised for a mirror to be put out in the front room, and we noticed that the kids are using it a lot, and then from there we'll just say to them, you know, what do you think your faces look like today? Is it clean or does it need cleaning? And then we can assist to clean it, so it's all a part of the hygiene business. But that mirror's been a great help.
I think what kids tend to walk away with at the end of a program is that clean faces mean strong eyes, and I know that that's branded throughout the Trachoma Story Kits, and it's a message that they seem to take home and enjoy. And you know, the kids will run up to you in the community and say, you know, clean face, strong eyes, see miss?
It's inspiring to know that even in a small community like Bulla, young kids are being taught how to prevent trachoma. Trachoma is only one of the causes of vision loss. Other causes include refractive error, cataracts and diabetic retinopathy. Diabetes is a common illness within our community, and people with diabetes need to have their eyes checked annually, or more often if problems develop. Prevention of eye disease is really important, so is early detection and getting the right treatment. Screening for vision loss is a big part of the eye care services, and fixing a problem may be as simple as getting a pair of glasses. Katherine is fortunate to have an Indigenous regional eye health coordinator, Dorothy Butler.
From the eye to check if there's any changes with your diabetes in your eyes. So just put your chin there.
Who works from the Wurlinjang Aboriginal Health Service.
Take a seat.
Dot coordinates the visiting optometry clinic, organises glasses and makes referrals to eye specialists.
Now sit back.
The main eye health problems that comes through my clinic is diabetics with diabetic retinopathy, cataracts, trichiasis. They're basically the most important ones.
Hey Dot. Hey
Hi,
Bertie,
Anna, what's the
I've got
problem?
a referral here. IC has been working in close collaboration with the Wurli Eye program, and particularly with the Regional Eye Health Coordinator, Dot Butler, for about the past 4 years. And that's been to provide optometry services regularly here, so that patients who are current clients of Wurli can access eye care regularly.
Now look up.
The main eye health problems in the top end are, I guess, similar to the main eye health problems in Indigenous communities, particularly in remote communities in Australia.
Right, chin forward onto here now.
Leading causes of vision impairment and blindness are refractive error. So that means people who need spectacles to correct their vision but don't have spectacles. Also cataract. And there's much higher rates of blinding cataract amongst Aboriginal people for a number of reasons, including lack of access to surgery or fear around having surgery.
Oh, that all looks fine.
So if you have a look here, Rayleigh, this is like an example of an eye that's just cut in half so we can see. Another leading cause is diabetic retinopathy, So that's where there's bleeding on the retina, which if unchecked can cause a vision loss which generally can't be returned. Particular emphasis is given to diabetic patients so that they can have annual dilated retinal exams. The blood vessels in the retina looks normal. Sometimes in diabetes that can cause some leaking. So you can see those little patches of blood that's leaking out of the retina.
What I'm going to do today is take a photograph of your eye to check if there's any changes with your diabetes in your eyes.
All the diabetics have to be screened once a year, and so I try to make it out to each community once a year and try to see as many diabetics as possible.
That's your macula there, that's your seeing part of your eye, and that's nice and clean. This is your optic nerve here at the front. And you've got a very good eye. No diabetic retinopathy, no changes in your eye. So I'll see you again in 1 year's time. Okay.
Also, we see all the clients that require reading glasses, and I organise glasses for them and do ready-made readers for them.
So what you need to do is select a frame. And they're just frames.
Across Australia, it was estimated there were about 120,000 Aboriginal people who were not receiving, a basic standard level of eye care that they should be receiving.
Oh, they're better.
They're nice. I reckon they look better.
The IC's programs enable access to low-cost spectacles, and that's been recognised as one of the main barriers to improved vision in Aboriginal people is inability to affordably correct refractive error.
Oh, these are much better.
Morning, Michelle.
There are so many links in the chain in the eye health system, from early detection, so that involves Aboriginal health workers especially, also people wanting to access those services, and that's where the role of the Regional Eye Health Coordinator is so important.
Monday, would you like to come this way? I'm going to check your vision. Hand like that, over your eye, then you look up there and you point. Right, cover one eye up, start from the top and point which way it's going.
They provide that vital link to the community as trusted members of the community in which they live, and also making sure that the optometrists who provide the services are culturally aware and practice in a culturally appropriate way to make people feel comfortable about accessing those services, and then ensuring that referrals to other levels of eye care are followed through.
The challenge I have for running the program is getting the clients to come in. We have a system here where I've got a bus driver. I give them the list, they go out to the communities, pick the clients up, bring them here and then take them back again. The problem that I have sometimes is when I have to refer the clients to the Katherine Hospital.
So do you think they'd be able to handle this referral at the Katherine Hospital?
What's your current wait list like for cataracts?
It's pretty long.
Yeah?
It's really there's more than 12 months wait list there.
Yep. Good idea might be have a chat with her, see how she feels about going up to Darwin. She could have a family member obviously go with her.
Right, hello Tuan.
Hello.
Come to have your eyes tested. You had them tested before?
No.
Good, okay. So
The optometrist visits Wurli 3 to 4 times a year. We do normally 4 to 5 days service.
And
I decided to remote area locums for a number of reasons. Firstly, professionally, I think there's a great value in being able to provide eye care to remote areas. I find that particularly enjoyable. I think professionally it's a challenge because obviously the clinical work that we do here is far different than we do in our own practices at home. Do you notice any difference if I do that? What difference do you notice?
it'll like go bigger.
Go bigger, good. Yeah. She's short-sighted, she's a bit mildly long-sighted, which is not uncommon. What that actually means, their eyes have to work harder. They focus to keep things clear. Okay. So if she is struggling with her schoolwork or finding the eyes are uncomfortable with reading, we'd give her glasses for schoolwork.
Look up here at my finger.
There's a number of organisations that provide locum optometrists for remote area health programs. I go with IC and they regularly send me updates on the positions that are available for different parts of the Northern Territory. I find something that I like, a place generally I haven't been to before, and say that suits me, and off we go.
This one.
And we're finding that the more locum optometrists get involved, the more it spreads by word of mouth about how great the program is, and we're continually contacted by optometrists around the country who are keen to get involved in our programs.
The role of the Regional Eye Health Coordinator is crucial in connecting people to the best services. However, long distances and lack of transport mean that it's still difficult for our people in remote communities to access eye care. So what about taking the eye care to them? Eye specialist Dr Tim Henderson and his team travel out to Trichiasis community to conduct a remote outreach clinic.
The Central Australian and Berkeley Integrated Eye Health Program is all about providing really good care as close to where patients live as possible. The region that we cover is around 1 million square kilometres. It's about the size of Spain, but we cover as far north as Elliot and as far south as the South Australian border. We go out to Kintore and Docker River down in the southwest, and we go as far east as Lake Nash, which is only a couple of hours out of Mount Isa. I think it's 32 different communities over a year of visits, but some of them are larger than others, and so we visit several, 2 or even 3 times. Normally we will try and arrive at the community at around 9 to 9:30. The patient list will have been prepared beforehand so that we can actually target the patients that most need to be seen, rather than just having everybody turn up who feels like it. 30 to 40 people that might need seeing, records of some others. We will normally try and make sure we put as much information on their primary health database system so that they've got access to that, which does mean that when we do see people coming in unexpectedly, we've got background information from a baseline assessment some years before sometimes, and that's really helpful for comparison. So the aim is to do as much specialist service delivery in the remote community as possible.
Sarah, how are you?
Good, thanks.
What about this one here? On top of my finger?
What we try and do is have optometrists visit the community some weeks or months before we're due to visit with the eye team, so that they can actually provide that comprehensive screening service and allow everybody who wants an eye check to have a formal full eye assessment.
We'll just adjust them, make them a little bit firmer there. That's all right. That's all right? Yeah.
But the aim is to try and see less people and do more for them, so that we're actually concentrating the specialist services where they are most needed. Because if we start to see any problems from the diabetes, we can actually do some laser treatment to try and shrink down those blood vessels and stop them damaging the middle bit. I think one of the things that has helped with the building of the service and the development over the years has been the continuity that's been possible with all the different organisations actually working together. The problem with a lot of short-term funding and short-term programs means that you often get very transitory staff. And that's still a recurrent, serious problem in the delivery of healthcare within this environment. Because we've now got a structure in place, we're able to provide a greater degree of continuity, and that has built up an important level of trust, an important track record as well. That's lovely. Have you got any other questions or anything else that you wanted to ask, anything you're not sure about?
No, that's right.
That's all right.
Yeah.
Those drops that we put in, they just take a couple of hours to wear off, and then you'll be back to normal tonight. I'm sorry it makes things look real bright.
Yeah, let's make it good, right?
Yeah. All right, thanks, Marie. See you next year.
Yeah.
I think all patients in Australia deserve exactly the same high standard of eye care. It's just a bit more of a challenge providing that in the remote locations in Central Australia, and that brings all its own challenges, but makes it that much more rewarding to achieve.
Tim and his team provide a wide range of care without people having to leave their communities. However, when surgery is needed, patients have to travel to a bigger centre, such as Alice Springs. Many of their operations are for cataracts, a condition in which the lens of the eye clouds over. Next, we'll see Tim performing a cataract operation. Be warned, it's graphic.
Cataract surgery has got its own particular challenges in Alice Springs, not least the difficulties of getting patients to come in. But I guess because the population that we're dealing with often present late and are quite reticent about having surgery, and very often we will have visited communities a number of times before people will come round to the idea. Quite often we have to wait until relatives or friends have had surgery, had a good outcome, been able to tell them that this actually wasn't as bad as they thought it was going to be, and for patients to actually learn from those familial experiences. It's very interesting within the Aboriginal communities that the one bad experience of one patient will affect the whole community. So it's really important that the messages that go back to communities are positive, but it does take time to overcome the barriers of uncertainty, reassuring people that we do not take the eyeball out, that we do not use part of a cat's eye for the operation, and that it's actually a relatively straightforward operation which can be done very safely. Cataract surgery is an extremely satisfying but also challenging process. The procedure is, on the face of it, very straightforward. All we're doing is a very small cut in one part of the eye, the outer part of the front window, in order to allow us to get a very small tube inside the eye, break up the cataract, take out all of the cloudy components, and then put a small, fresh, clear lens in. Because the lenses that we usually use now are able to fold up, we're able to do the whole operation through a small cut, less than 3 millimetres in size.
Just keep at it before you...
If everything goes well, it looks easy. There are potential problems at every single stage during the operation, and the aim is to try and avoid running into any difficulty at any stage. It's been interesting having the comments of experienced surgeons on the workload that we're actually doing within the surgery weeks. And one of the helpful comments for me was somebody saying that the frequency with which they see really difficult cases back home, for example in Sydney, would be around 1 in 50, whereas in Alice Springs it was 1 in 5. There are strong taboo reasons around patients not wanting to come into hospital, and yet it's the only safe place to do an operation that will give them the best chance of a good result. Patients are not comfortable being in theatre, they're not comfortable being indoors, and a lot of the issues around making surgery possible is about making the patients feel comfortable, and that means that we're quite happy having relatives come in, interpreters come in, people sit and hold the hand during surgery so that if they've got any problems they can simply squeeze that hand and we can find out what their concerns are. The nice thing about operating on difficult cases is that the impact for patients is often very dramatic. The story that I often tell is for an elderly gentleman from one of the remote communities northeast of Alice Springs who took a long time being persuaded to come in for surgery, and he went from count fingers vision, which is not even being able to see the top letter on the chart, to being able to see again well enough to drive, to shoot, to run the night patrol, and to fulfil his obligations as an elder to the younger men within the community. And his description to the remote doctor, who had been looking after him for a number of years, was that he felt it was like getting his manhood back. That was the impact for him on his life of me doing a simple operation.
We have been achieving good results in our communities, but there's still a long way to go to prevent and treat all the vision loss. It's important to get regular eye checks to screen for infection and other eye diseases. The earlier that problems are detected, the better the outcome. Let's make sure that all our people see strong.